The federal public health emergency for COVID-19 officially ended 15 months ago. But any healthcare provider will tell you the official date means little because the pandemic's repercussions for hospital and health system workforces lingers on. It's felt every day. While the great migration out of the healthcare profession has slowed, it's not over. Nonetheless, caregivers are finding ways to cope and continuing to deliver great patient care. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle with AHA Communications. Corewell Health, which provides care to a large section of Michigan, also faced a shrinking workforce during the pandemic, as so many providers did. In this podcast, we learn about its response, which can be summed up like this. Instead of saying we'll do more with less by making people work harder, we said, how do we do more with less by thinking outside the box and reinventing some of the things we did?
Thanks, Tom. I'm Elisa Arispacochaga, AHA Vice President of Clinical Affairs and Workforce, and today I'm really excited to have a conversation with Dr. Darryl Elmouchi, Chief Operating Officer of Corewell Health, where he leads strategy, operations, and clinical care delivery across 21 hospitals and is dealing with all sorts of challenges related to the workforce and really supporting the teams that he gets to lead. And I'm excited to have him share with this group some of the amazing work that they are doing and piloting and innovating to really support their workforce. So to get us started, Darryl, can you tell me a little bit about your background and sort of how you came to this role from your clinical work?
Sure. So thanks so much for having me. I'm excited to be here. I am what's called a cardiac electrophysiologist. So a cardiologist who did very specialized procedures for heart rhythms and never, ever intended to be standing here talking to someone like you. But over the course of many years, and you'll see a theme here when we talk about some of the work we've done, I came to see not only caring for patients being important, but for caring for people that care for patients to be important, and really saw a need to make systems better. And so started down that path well over a decade ago. And over the course of many years, took on different jobs trying to do that. And over the last few years, have been really leading all care delivery for Corewell Health. And if you recall, Corewell Health is actually two health systems emerged about 2 years ago, Spectrum Health and Beaumont Health in Michigan.
You're covering not only the entire state, but really trying to make sure you're supporting two different teams and bringing those cultures together. So that's definitely a challenge. And I know we've talked about this. You're facing the same workforce shortages and challenges with turnover and the overall impact on that care team. So not only are you trying to support them, but you're trying to support a team that may be tired and worn out and needing some extra supports. And quite honestly, they're fewer than maybe they were before. So what are some of the biggest challenges you've been seeing and some of the drivers of dissatisfaction that you really wanted to tackle as you started thinking about this work?
Yeah, I think you kind of hit it very well. And I'd say a couple things. Obviously, I think for everyone coming out of COVID, it was just a year, 2+ that was incredibly challenging emotionally, physically, in every possible way for caregivers. And then coming out very specifically, we saw, like everyone else, this migration of folks that were no longer in the workforce, whether it was early retirements of nurses or people that came into the workforce and pretty quickly said, I can go do something else that's easier. I don't have the calling that I used to have. And so we were trying to do the same amount of work or more with less people. And ultimately, that just is a recipe for burnout, and it doesn't work. So we took a multi-pronged approach, and I want to preface this by saying we're on a journey. There's nothing that's perfect, but I really like to pride our teams and some of our leaders, because instead of saying, how do we do more with less by making people work harder, we said, how do we do more with less by thinking outside the box and reinventing some of the things we did? And I'm really proud with some of the pilots that we've been now starting to scale. I'm happy to share a lot of them if you'd like.
Absolutely. I know one of the areas you've really sort of double clicked on is looking for ways to incorporate technology, which is not something that clinicians have, had a real good track record with. Let's just put it that way. But looking for ways to incorporate that technology that can reduce the burden, particularly that administrative burden that is not why you went into healthcare. You went into healthcare to help people, and, typing up their complaint list doesn't feel like it's helping them. So what are some of the ways that you have been using technology to really augment the ability of the team?
Maybe I'll start with nursing because I think probably across the country, that's been the area that's probably been the most challenging in terms of workforce and how hard it is to both hire and continue keeping nurses, as well as attracting new nurses into the field. We've done a lot of things like many other, working on pipelining, partnering with universities and so forth to try to increase the number of nurses in the state. But in addition, we had a team that looked at what are nurses doing, particularly in the hospitals on the floor? What are they doing minute by minute? And how much of that work is really not value add? It's not what they went to nursing school for. It's not what we really intended to hire them to do, but they're doing. And maybe I'll turn and ask you just a quick question. What percentage of what a nurse does every day in the hospital do you think is really kind of clinical, needing a nurse, versus anything else?
Well, I only know the answer because I've heard you talk about this, but I was shocked because I would have thought it would have been in the 70 to 80% range before I heard what your study showed.
So we did very detailed pilots looking on different nursing floors to understand what nurses do. And as it turns out, direct patient care is about 44% of their time, meaning 56% is something other than direct patient care. And even within direct patient care, a large percentage of that is documentation. And that's not necessarily truly direct patient care, but you'd argue that a nurse probably has to document. So there's a huge amount of other work. And the hard part about this is that as we learned and we dove into this, that other work isn't work that doesn't have to be done. It absolutely is. It just might not have to be done by a nurse. And so what I would share with you is this: if you start thinking about what a nurse does, aside from going in and adjusting medications, giving medications, assessing patients, checking vitals, all the things that clearly are part of a nurse's toolbox, there are so many other things that happen that are really challenging for nurses. So think about everything as simple as a patient wanting a glass of water. That's really important for that patient. For the nurse, probably someone else can do that. Going to find supplies on the floor. So many other things that they're coordinating and trying to do that really aren't that helpful. So what we ended up doing, and this is a really interesting way that it was piloted, we said, well, is there a way for patients to let us know what they want in a room that uses technology? And by use of that technology, can we use another workforce to do some of that work? And we started this pilot now about 2 years ago in one of our smaller rural hospitals. And we actually had an Alexa, so an Amazon device, and created an interface and an app on Alexa where the patients could talk to that. And the first thing we learned was it totally didn't work. It just didn't work at all. Patients really, it couldn't understand them. The patients themselves really couldn't figure out how to use it very well. So we scrapped that and we partnered with a local entrepreneur and actually created an app. That app can go on an iPad or typed a tablet device in a room. The app also we put on nurses' workstations and their devices they carried around the hospital. And what we learned is that there is a ton of requests, or there are a ton of requests for these nurses through this app. We started adding more requests that someone else could do. So the second thing we did was we temporarily hired a distinct workforce where we more or less, and for lack of a better term, gamified or Uberized what they did relative to these other tasks. So if a patient needs a blanket, the patient clicks on the app, they need a blanket, someone else in the hospital who's hired to do this brings them a blanket, and they could be coming from another unit. And that person gets incentives to do more over the course of time. So almost like an Uber driver who gets incentive to drive. We started working on this more and more, and we realized that actually the most clicks from the app came not from the patients, but from the nurses themselves when they were tasked with something, when they came by a room, they saw something was needed or asked, and they can actually ask someone else to do it for them. And we have now scaled this across multiple nursing units at large academic 1,000+ bed hospitals and at smaller hospitals. And it has been incredibly effective.
I just love this idea. And I especially love that you went back to it even after the first version didn't quite do what you needed. I just love the idea of being able to really look for ways to create that delegation chain in a way that doesn't feel like you've got to, then train another workforce and pull them in. This is work that can be done in a way that that really doesn't put another burden on the nursing team to figure out how to get it done. So can you tell me a little bit about what you're doing to bring some of those teams together so that you can reduce some of the frictions? I know we often set workflows in healthcare and then they are set in concrete and we never move them. But to try to make the teams more efficient, especially when you're working with maybe people you haven't worked with before, or you're trying to do different things with that smaller team.
Yeah, I love the question. And I say that, if you think about kind of some of the universal challenges in modern healthcare delivery, one of them is everything's become so big that it becomes more impersonal. We're just tribal. We like to be around people that we get to know. We understand how they work, how we work. And in large hospitals, large clinics, large systems, that becomes increasingly challenging. So I'd point that as just one underlying problem that really takes away from the family feeling of things. Number two, as a health system, we had issues with our length of stay. We wanted to work on making our length of stay better. I firmly believe a shorter length of stay improves the patient experience because they're not waiting for things in the hospital. They can be home and not lying in a hospital bed. And it allows us to use our resources more effectively. And as we were looking at both of those problems, we had different teams kind of looking at them. We realized there's a very simple solution, which quite honestly, it's quite possible many of our members have done years ago or never went away from. But we started realizing that particularly in our larger hospitals, we had people all over the hospital and very few areas where there were kind of similar people that were working together all the time. And very specifically, this has to do with the move to hospitalists and physicians. So we have large hospitalist program, and we had hospitalists that were at our largest hospitals, over 1,000 beds, going to 6 or 7 nursing units in a given day to round because they were caring for a patient here, a patient there, and so forth. And as we started working on length of stay and doing what we call care progression rounds, where you have a case manager assigned to a floor, a nursing unit manager assigned to a floor, you realize they'd have to call in the doctor who's running from somewhere different, and that just didn't seem to make sense. And when we started thinking of both of those problems together, we said, the more we can try to cohort patients, doctors, nurses, care managers in the same area, the same unit, the same floor, the more they can work together, not only in this shift or for this week when they're working, doctors are often 7 days on, 7 days off in these areas, but over time they can develop long-term relationships that really help strengthen that bond and have people work together well. And it's been incredibly positive, both from a well-being standpoint and from a length of stay standpoint.
That's awesome. It's reminds me of one of potentially the hokiest movies that I'm a big fan of, but the Apollo 13, and where, Tom Hanks starts talking about, wait, you want to change one of my team members when, we know the way, the sound of each other's voice, the tone of our voice, how we react, and all of those things. And it's so important to not underestimate the value of that teamwork and that connection among our clinicians, particularly when they are dealing with much more stressful times, patients who are sicker, all of those things that we're seeing now. I think it's really a great approach, and, always nice when it also helps reduce length of stay and make the patient experience better. But I can't imagine it doesn't really make those team members feel really unified as a group.
Absolutely. There's such much more cohesive feeling. And, and I'll be very honest and say that if we look at our particular larger hospitals, somewhere between 50 and 80% of the units were now able to do that. We call it cohorting. We were 0%, a few years ago. So we've made a lot of progress, but there's probably a limit to what you can do just based on the nature of variability within healthcare. But even that 50 to 80% has made a huge difference.
As you're starting to think about this, and especially going into the future and starting to change workflows and the work environment and thinking about the team a little bit differently, I don't know if you guys coined the term, but I love the idea of someone being an inboxologist, and I'd love for you to share a little bit about that.
Yeah, so this one could be one of my favorites. I'm a little biased as a former practicing physician. So when I started in clinical practice, about 20 years ago, there were no EHRs, at least where I was. And so I was so used to, you work, you go home, you work, you go home. And when you're home, you could be on call, but you're not finishing notes at 2 a.m. You're not jumping in the inbox because of alerts and so forth. And nowadays, anyone who works in an electronic record, regardless of what it is inundated with inbox messages. And that essentially is like your email in basket, but for clinical issues. Some of those are very important. Some of those are more informational and less important, and it becomes truly overwhelming. And so we started looking, and many of the modern EHR vendors, we happen to have Epic, can give you all sorts of data on what we call pajama time. So how much time clinicians are spending after hours, generally when they're home, in the in-basket. And you could look at how much time during, say, a clinic day they're spending doing things in the in-basket and in the EHR. And it is mind-numbingly frightening where we've come. So you talk about burnout amongst the physician and APP workforce. It is completely understandable. And you even go a step further and you say, in the beginning of COVID, electronic messages to providers were common, but not commonplace everywhere all the time. They've skyrocketed, if you look at data across the country, anywhere from 3 to 6-fold post-COVID. So, and that's just new work. You're not getting necessarily paid for it. You're not allocating time for it. So we started looking at what can we do to make life better. And we took it on 2 paths, a technology path and just a rethinking the workflow path. And I'll start with the latter first. And we said, there's a lot of stuff that comes in this in-basket that absolutely needs a clinical eye on it, but probably can be addressed without the top of license in our workforce physician looking at each of these. And so we decided to create a pilot. We called this the Inboxologist, and I'm pretty confident. I don't know that we're the first person to think of this, but we're definitely, I think, the one to coin the term. We actually have a publication coming out relatively soon on our data for this, for the Inboxologist, which is what we call an APP, a physician assistant or nurse practitioner, specifically hired to manage the inbox of a number of clinicians. Started with just physicians, but they actually could be managing the inbox of other APPs that are in the clinical workforce. And the goal was to see, can we decrease the amount of burden on the physicians and APPs that they're doing this work for? Can we decrease their pajama time? And our hope was, and this was kind of our underlying assumption, that this would improve productivity enough without us asking for anything in return, that it would at least break even and pay for itself, because you have to find something sustainable in this world. The second big issue we had with it was, would anyone want to do this? If we're going to advertise for this role, would anyone want to be in the in-basket all day as part of their job? Well, we started probably 1.5 years ago, and I can tell you it has been amazing. So first of all, would anyone want to do this? I think I recall us having somewhere like 2 or 3 dozen applicants for the first 2 open positions. It turns out that there are a lot of APPs that really like this work. They can do this from home. The hours are pretty flexible. And so it's a pretty nice lifestyle work, and it's still important work. The second part of it was, can we scale this and make it work? And we had a lot of learnings to do, because we didn't know, do you say that one APP covers 10 doctors, covers 5 doctors, and it turns out you really have to adjust this based on the panel size of the physician or APP, the type of work they do. We really started in primary care thinking that's where the biggest burden was. And I can tell you that the data has been absolutely spectacular. I'm going to actually share you our most recent data, which came out about a month ago. So the average physician who is enrolled in this, meaning they have an inboxologist, spends an average of 77 minutes during daytime hours less in their in-basket each day, so 1.25 hours, and 95 minutes less each night of pajama time when they have an inboxologist. The work-life balance of these providers went from, on a scale of 0 to 5, 5 being the best, went from a 3 to a 4.25, with this being the only intervention. And we've seen a 41% in-basket reduction volume. So either it doesn't come to them because it's something the APP can be addressed, or when it gets to them, there's a narrative around it where it's very clear kind of where to look and what to do. It has been spectacular.
Well, you've given them most of a day back in a week.
Can you imagine? And I'll share. And so the big thing for, my CFO colleagues is, when you look at this, we also had that idea, like, what will happen? How will this work? And so we have now determined that just about everybody who goes through this, has enough time on their day where they will see an extra patient in the clinic every day, every few days, what have you. And when you add it all up and you also look at decreased turnover, it actually pays for itself and a little bit more.
I love talking to you because you give me so much hope for the work we do in healthcare. Darryl, I can't thank you enough for sharing these great pilots that you're working on, and I hope we can revisit sort of where Corewell Health is taking this into the future. I'm super excited for all the work you're doing and the ability of the rest of the field to try taking these on. Thank you so much.
Thanks so much for having me. It was a pleasure.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.